Imagine a patient walks into the clinic, and their body is basically acting like a broken faucet. They are losing massive, and I mean almost unbelievable amounts of water every single day. Now, this isn't your everyday run-of-the-mill dehydration. We're talking about a state where the body completely loses its ability to hold on to free water. So today, we're going to explore the precise mechanisms, the diagnostic detective work, and the treatments behind the condition known as diabetes insipidus. Here's our roadmap for today. We'll hit Section 1, the endless thirst. 2, how ADH normally works. 3, 2 types of malfunction. 4, playing detective, the diagnosis. And finally, 5, resolving the issue. Let's get to it. Section 1, the endless thirst. Uncovering the symptoms. Let's see how this mystery actually builds, starting with those very first clinical clues. Look at this number right here, 20 liters. That is how much dilute urine a patient with diabetes insipidus can pass in a single 24-hour period. To put that into perspective, just picture 20 large liter bottles of water literally draining out of the body every single day. This urine has a super low specific gravity and osmolality. Because the body just can't concentrate it, it's just dumping free water straight out of the system. And naturally, this massive fluid loss triggers a whole cascade of severe clinical features. We start with polyuria, which is that immense volume of dilute urine, and that directly causes nocturia, forcing the patient to wake up constantly through the night, so obviously leading to restless sleep and daytime exhaustion. To compensate, they develop polydipsia, this extreme, completely insatiable thirst. Now, if their thirst mechanism is intact and they have access to fluids, they might just scrape by. But if water intake is low, say in an unconscious patient or someone with damage to the hypothalamic thirst center, this rapidly spirals into severe dehydration, hypotension, altered mental status, seizures, and even coma. Section 2. How ADHD normally works. The body's water dam. To understand how the body fails so spectacularly, we've got to first understand how it succeeds when everything is functioning perfectly. Check out this elegant macro feedback loop. Our hero here is antidiuretic hormone, or ADH, also known as vasopressin. You can think of ADH as a really strict dam operator. Receptors up in the hypothalamus are constantly measuring plasma osmolality. If the blood gets a bit too concentrated, meaning osmolality exceeds a certain set point, the hypothalamus signals the posterior pituitary gland via a neurosecretory tract to release ADH right into the bloodstream. ADH then travels all the way down to the kidneys to trigger water retention, dropping that plasma osmolality right back to normal. And this graphic brilliantly illustrates what happens when we zoom all the way down to the cellular level. When ADH reaches the kidney, it binds to a specific V2 receptor on the cells of the collecting duct. This receptor acts kind of like a molecular bouncer. The binding stimulates adenylate cyclase, converting ATP to CAMP. This spike in CAMP activates protein kinase A, which then phosphorylates and activates aquaporin 2 channels. These aquaporin channels rush to the cell wall, throw open their gates, and rapidly pull free water right out of the urine and back into the body. This is literally how the dam holds the water back. Section 3. 2 types of malfunction, the villains of our story. So, what happens when that dam breaks? Well, that's the inciting incident of our mystery. This water retention system basically breaks down in one of 2 distinct ways. We are essentially looking at 2 totally different villains. Over on the left, we've got central diabetes insipidus, or cranial DI. This is the problem at the source. The brain, specifically the hypothalamus, simply fails to produce enough vasopressin. The signal is just missing entirely. Then on the right, we have nephrogenic diabetes insipidus. In this scenario, the brain is practically shouting the signal, producing plenty of ADH, but the kidneys are completely ignoring it. The renal tubules are totally unresponsive because of defective receptors or channels. So the really crucial point here is how these malfunctions actually show up in the body's chemistry. Because the free water isn't being pulled back in, the patient ends up with a hyperosmotic volume contraction. Fluid is lost, so the extracellular fluid osmolarity shoots up. Take a look at these urine osmolality numbers. A normal person's urine concentrates between 500 and 800 milliosmoles per kilogram. In partial DI, it drops to about 300 to 500. And in complete DI, the urine is incredibly dilute, dropping way below 300 and honestly often even below 100. Section 4. Playing detective. The diagnosis. Solving the case. We've got our symptoms and we've got our suspects. Now, let's step into the shoes of a diagnostic detective and walk through the brilliant structured logic used to solve this exact case. As any good detective knows, you've got to establish your baseline facts before running any complex tests. So, the absolute first step when DI is suspected is ordering basic lab values: sodium, plasma osmolality, and urine osmolality. These three initial numbers are basically the key to unlocking the entire diagnostic pathway. This flowchart is fantastic for showing the immediate branch point in our logic. If those initial labs show hyponatremia, meaning low sodium, along with a low to normal plasma osmolality, we're likely looking at primary polydipsia. That just means the patient is compulsively drinking way too much water. But if we see mild hyponatremia, high sodium, with a high normal plasma osmolality, while the urine is still super dilute and low, then diabetes insipidus is highly likely. Once we strongly suspect true DI, we've got to prove it using the confirmatory water deprivation test. This is a pretty rigorous protocol where we stop the patient from drinking any water for a set period. We measure their body weight, urine volume, and osmolarity every single hour, and their plasma osmolarity every 2 hours. We are literally denying them water to force their body to concentrate the urine. If the urine osmolarity naturally rises above 600, well, DI is ruled out. But if the plasma osmolarity climbs and the urine stays completely dilute, boom, we've confirmed the diagnosis. Now we just need to figure out which type of DI we're dealing with to finalize our case. We administer desmopressin, which is a synthetic ADH, and we watch the graphs. Look closely at the bottom graph for urine osmolality. If we give the synthetic hormone and the urine osmolality suddenly spikes upward, it means the kidneys work perfectly. They were just missing the hormone. That confirms central DI. But if we give the hormone and that light blue line stays completely flat, it means the kidney receptors are broken, confirming nephrogenic DI. I want to pause here for a massive clinical pearl directly from our sources. This quote is absolutely vital. You must never give DDAVP, that's synthetic hormone, to a patient who actually has primary polydipsia. If a patient is compulsively drinking massive amounts of water and you medically force their kidneys to retain all that fluid, you are going to trigger severe, potentially fatal water intoxication. That is exactly why the baseline labs and that step-by-step logic we just went through are so incredibly important. Section 5, resolving the issue, restoring balance. All right, once we've safely navigated the diagnosis, it's time to fix the broken dam. Let's look at the therapeutic resolutions for both of our identified villains. For central DI, the treatment is beautifully logical. The brain isn't making the hormone, so we simply replace it. We use desmopressin. What makes desmopressin such a real game changer is that it's a synthetic vasopressin specifically designed without the unwanted vasoconstrictive side effects of natural ADH. It just does the water retention job. It's most commonly administered intranasally, though it can be given subcutaneously or orally too. Now, treating nephrogenic DI requires a completely different strategy because the kidney is just completely ignoring the hormone. First, if a drug is causing the unresponsiveness, like lithium or democlocycline, you obviously must discontinue the offending agent if at all possible. We also paradoxically use thiazide diuretics and NSAIDs to help manage the condition. And most notably, for patients with lithium-induced nephrogenic DI, amiloride is indicated. Amiloride acts as a highly targeted fix because it specifically blocks lithium entry through the sodium channels in the kidney, which allows those cells to actually recover. It really is incredible when you step back and look at the sheer scale of this whole system. I mean, how can a single microscopic hormone released deep inside the brain dictate the movement of up to 20 liters of human fluid balance every single day? It's a true testament to the astonishing, high-stakes precision of human physiology, and exactly why understanding these mechanisms is so absolutely vital. Thank you guys so much for watching. I hope you enjoyed all the graphics we made for this one, and as always, thanks for tuning in to Mid Medicine.